Hi, everyone. Good evening to tonight's Board of Health meeting. Today is September 9th. We are here in the Town Hall. Our first item for today, we're going to discuss the opioid settlement funds with our friends in public safety. We'll start off with a brief overview from Matt and then pass it over to public safety, and then we'll open it up for discussion. Anyone in the room who would like to discuss anything, we just ask that you come to the front because we are live. And you speak into the mics, state your name, your affiliation, or your address. And if you do speak, we just ask that you sign in. So, Matt, thank you.
So just because we're all here today to speak about the opioid funds, I figured I would just kind of give a brief background if someone's watching at home for the first time on kind of, where we've been so far. So in 2021, the Mass Office of the Attorney General began offering towns mass opioid settlement funds through their legal settlements with opioid manufacturers, distributors, and pharmacies. So information was provided through the local boards of health through DPH about this process, which I relayed at the time to town management, which was Bill Keegan. And through this effort, we were able to sign up for all the funds. However, we did have setbacks. When Bill retired, we had not allocated the funds in an appropriate account or had been able basically to create a process to use them. But once these funds were transferred into an account where we could use them, and we were under new leadership, the health department surveyed residents and stakeholders within the community in regards how they wanted us to use these funds. Justin presented those to you at a previous meeting. The copies of that presentation are on the table. Basically, what the town of Foxborough, what the survey said was 46 out of the 80 some odd people who took the survey said they wanted to support people in treatment and recovery. 33 wanted to prevent misuse of opioids and implement prevention education. 21 wanted to use it for opioid use disorder treatment, 18 for harm reduction, and 18 for connections to care. And then when we asked broader questions, like, would you like us to provide more education in the schools, 80 said yes. Would you support increasing the amount of resources available to first responders? 80 said yes. Would you like the town to better support local opioid treatment and recovery programs? 81 said yes. And would you like the town of Foxborough to offer Narcan training and distribution? 82 said yes. And one of the biggest takeaways that I found is, should the funds be used for single or multiple programs? 71 of the 88 people in the community said they would like the town to use this for multiple programs. So based on that information, we wrote up our basic findings, which we saw the priorities for the town would be to support people in recovery, prevent misuse of opioid and implement prevention education, harm reduction, and opioid use disorder treatment. Department heads then met after that. We had a lengthy discussion and we all shared our ideas. I also surveyed, at the request of the town manager, department heads and asked them what they would want to do with the money. When you asked that specific question, what they would do, 7 said they'd give it to local support groups, 7 said continue to fund Interface, 5 said more school education, and 4 said social work. When asked to rank the importance of the proposed activity to the community itself, social worker ranked highest, then Interface, then local recovery, Narcan, education, then harm reduction and sharps. Lastly, 6 department heads requested they'd like to come back on a yearly basis to the table to reallocate funds as needed. So after hearing the thoughts of the residents, the Board of Health and Health Department, Justin, a master's student at UMass, he looked at all the ideas independently. He reviewed them to scholarly literature as part of his practicum experience for his master's degree at UMass Amherst to give to the decision makers, when giving final approval for the use of these funds. And it's available on the table if you would like it. And I'd like to thank Justin, if he listens today, for all his hard work. He really did. He worked hard this summer. I had him work a lot, and he did a great job. So today, public safety's here. They're going to give us their opinion in hopes that we can come to a unified message that we can give to the select boards. So my plans were public safety, give them time to present their vision, and then take individuals' input here today. And then have the board discuss their previous motion to the select board. But I just want to remind people of, kind of why we're here and the commitment to these funds, or the state says, by receiving these funds, municipalities have a shared commitment to use these funds to strengthen resources available to communities for substance use disorder prevention, harm reduction, treatment, and recovery in a manner that, 1, reflects the input of the community, 2, addresses disparities in existing services, and of individuals disadvantaged by race, wealth, and stigma, address health conditions, and leverage programs already offered by the state or BSAS. And it encourages innovation, filling our gaps, and fixing shortcomings. So, that being said, I'll hand it over to Christina.
Can we just go across the table and you state your name and your positions, please? Thank you.
Yes, I'm Mike Grace, the police chief.
Christina LaRose, Community Response Social Worker with the Foxborough Public Safety.
Tom Kemen, Deputy Chief, Emergency Medical Services and the Public Health Nurse.
Mike Kelleher, Fire Chief.
Hi, I'm Jen Rosenberg, School Nurse Leader, District Nurse Leader.
And we wanted to introduce ourselves to you. One of the board members, Robin Chappelle, who's been a long-time resident of Foxborough.
I'm Betsy. I'm the chair. I've been here for a few years.
Yes.
Sophia, board member. Vice chair, I forgot. Yeah.
Okay.
So real quick, I think instead of all of us giving an open statement, we've put a presentation together that we'd just like to kind of roll right into. That way we're not repeating ourselves, and we can kind of stay focused and on topic. Is that okay with the board?
That's fine.
That's great.
All right, Tom, you going to be the narrative? And
We'll start, sure. Do the clicker.
Yes, oh boy. A lot of pressure here.
All right, so in discussing ways that we can tackle opioid use disorder in Foxborough, it's incumbent upon us to recognize all the different overlapping scenarios that we come across in public safety, emergency medical services, with our collaborators at the school department, with the school department, Council on Aging, Human Services, and our local hospitals that we transport to. Looking forward to the survey results that Matt had discussed, we did take that into consideration. That's a huge thing. And leading up to this, we did speak with the John Snow Institute, the JSI, who advises communities and towns on how to spend the abatement monies locally. One of the things we looked at was how can we really get to a position where we get hands-on at the ground level, real time, bringing all the resources that we have together in town, where we have a central hub to communicate through and disseminate information. And looking at the crisis intervention team, it looks as if we can put together the expertise of law enforcement, health department, social services, the fire department and EMS, and our local medical directors within Sturdy Hospital to kind of give us this more empirical, holistic approach to opioid use disorder at the ground level. So of the 88 respondents, I think the top key interest we found in the survey rankings was supporting people in treatment and recovery, preventing misuse of opioids, and implementing prevention education, and then harm reduction, which is a major topic that we'd like to focus on.
So to talk a little bit more about the CIT team and what that would look like to us, it's called the Crisis Intervention Team. Essentially be a multidisciplinary team, as Tom said, made up of EMS, fire department, public safety, police, health department, and potentially 1 to 2 clinicians. What that would look like would be essentially boots on the ground, people responding in real time to whether or not be a substance use crisis, whether it's a mental health crisis, and then also would give us the bandwidth to follow up after the fact. So a lot of times these calls come in, it could be on a weekend, it could be on when social services aren't in the office. So I feel like the follow-up really would be strengthened in terms of having the CIT approach.
So could I just jump real quick on that? So that concept and that team is not new to us. This is what we're currently doing with our domestic violence and our sexual assault follow-ups, using that entire team, following up at every level within the community, whether it be family, children, and staying with and following up on all of those cases from, say, their middle school families in the courts, and continuing currently to as long as they stay a resident in Foxborough, looking at 3, 6, 9 months, and then we start looking at 1 or 2 years, 2 years probably being the max, because that's as long as we've had the team together.
And do you meet like on a monthly basis?
The team is based on calls of service.
Okay,
So
so
we're
you do-
rolling, I think Christina could give you she could throw a number at you right near, of the hundreds and hundreds of calls and ongoing data that we have on every single follow-up and every single person that we're dealing with on this.
So excuse me a second, so does that crisis intervention team follow up together and discuss cases on a routine basis? That's what I meant by meeting.
Yeah, sure. So that's certainly the goal when we formalize this team a little bit further, and in terms of really calling it the CIT. Right now it's a domestic violence team, but that would be the goal, to at the very minimum have monthly meetings. I'd really like bi-weekly meetings with the core team members, and then potentially we would like to model it after. There's a few different departments doing similar work, and they call themselves a hub, so where we can be a point of contact for people like other department heads, other stakeholders in the community who might be worried about a member. You can present the case to the hub. We can de-identify the person, so it's no longer a breach of confidentiality, but now we can talk openly more about the real-time issues and what services we can kind of implement. And we would like to have other members on our team, from other departments, other services that are local to us, so we could all talk about high-risk cases, because likely we share many of the same cases, and if we could share resources and try to tackle those cases together, like, thinking of bringing like the Department of Mental Health to the table, a couple other people like that, so we can all kind of share the workload and understand better how we all work together and what we could each do.
One of the things you've really recognized, too, is that these gaps exist. And for people who are suffering from opioid use disorder, is that those safety nets, those social support networks are not there in place. So this takes a more proactive approach to reaching out rather than receiving requests for help. The goal is for this unit to reach out to those individuals and proactively offer them services or offer them care and support. So really, it's creating another safety net within the town of Foxborough. And to further expand what Christina was mentioning, so here we have clinical social workers would be the core. The goal of using the abatement monies would be to add a master's level substance abuse clinician to specialize in spearheading a lot of the different programs that come up during the survey that we want to touch upon, especially for Foxborough. EMS has always existed in terms of a role with opioid use disorders. We'll touch upon this a little bit later in a slide, but our paramedics respond several times a day, have a close relationship with our medical control hospital. Ironically, our medical control physician is also a physician at a substance abuse clinic, so she'd be providing oversight for some of the medical aspects that this program endeavors to pursue. And then obviously we have law enforcement, which is a key component of this. Law enforcement, their officers have gone through SHIELD training and enhanced training to work with patients suffering with opioid use and how to interact and encourage treatment and therapy for those individuals as well. So we're looking to avoid redundancy and duplication. What we've seen is some of these topical, more superficial approaches, where you have Narcan deposits in areas where maybe your high frequency users wouldn't be receiving Narcan, or training for folks that maybe don't have the interactions with folks. We're looking to kind of get to a point where we can have services that are in place and be able to expand those services to a broader net of individuals. We want this to be data-driven, and by data-driven, we want this to be real-time data. So we want to be able to act on things very, very quickly. I think what we just spoke to before with, creating another safety net in town is a lot of these individuals will get initial care or initial referral, and then it stops. So we want to tighten that with real-time data between all the different departments and agencies. I think one of the things we really want to do is decentralize decision-making to the lowest level and allow these individuals to make decisions and then collaborate, if weekly, if not daily, on how to make sure that we can address these gaps and address any concerns we have. And then again, the case management, I don't know if you know much about what Christina and her team have been doing. It's extensive. Along with the social workers and Jen and her team at the schools, they have been collaborating now in such a degree that it warrants us being here today to talk to you more about how we can use these monies to kind of better affect Foxborough. With community engagement and education, this is something that we could do from support groups to Narcan training to CPR to in-home assessments to all the different things that we can do support empirically, not only the patients themselves, but their caregivers and loved ones.
I think to add to that, the goal, if we do add another clinician onto the team, would be to expand our knowledge base and to be able to expand the services we already provide. One person can't be an expert in all of the things, so certainly what I would like to do is look for another clinician who has more experience with substance use, whether they have a background or whether they're a peer or whether, they have a passion for that and they have the education to back that and the resources and services. So ideally, we would like to add this clinician to also be able to offer in-person support groups to people who would like it. We were thinking about running 2 different groups. We haven't decided the location, but I'm thinking either the new community center, once that's built, or the library are both really great accessible places that are destigmatized. We understand the concern with public safety and working with those with substance use disorders. So, taking all of that into a consideration, the team wouldn't look like your typical public safety team either. It would be, soft uniforms, soft clothes when we're doing these follow-ups. They don't have to be at public safety. We go to people's houses right now as it is. We're meeting people where they are in their homes where they feel comfortable, or they'd like to meet at Dunkin' Donuts, they want to meet at the library. We're pretty flexible. So ideally, we want to break down silos. We want to be collaborative. We want to work with other departments. I think we all have people that cross our paths in more than one way. So I think if we start kind of communicating about what we're seeing in the community, I think we're going to have better outcomes, and we're all going to be able to kind of do our part to share in helping them. We need to share resources. I think we don't know what we don't know either. So I think once we start talking more together, we start realizing that there are resources out there. So I think we're talking about a lot of great resources right now, and they're already existing. So I think we're talking about Turning Point in Walpole, which is a beautiful funded program that does peer recovery support. We can still work with those kinds of agencies. We can make direct referrals to those people. What I'd like to see is us taking in people, bringing in speakers for some of these support groups, helping coordinate the school to get speakers to go out and do some of the education. And we're kind of just talking about expanding our communication reach and our outreach efforts. So I don't want to...
Just want to add one thing, too. I think in terms of, particularly Foxborough when it comes to opiates, I've been a paramedic in this town for 25 years, kind of lived through a lot of the opiate crisis, and it was... compared to 10 years ago, it was really bad. So I think things are getting better, certainly. But interestingly, Foxborough's experience, a lot of it is transient in nature, the patients. So they're not people that live in homes here. There's a number of hotels in this community. So I think that challenge particularly requires boots on the ground to kind of address that, because you have to work more to get these people in treatment and programs. There's things like human trafficking that occur that are an issue here. People don't want to hear that, but that's true. And I think there's a connection there to opiate abuse or substance abuse also. So I think it's important to understand, and working with Christina, you kind of get to learn how a lot of that follow-up requires extra work, because they're not permanent residents, they're transient in nature, so I think it's
Yes, thank you.
another dimension to the whole issue. So.
No, absolutely. That is something that we're seeing kind of a trend. And I think having this multidisciplinary approach will also help us when we come against some of those issues. It just happened the other day, we had an overdose in town, and we we went out with the police, and we went out with fire, and we're starting to think that this is more of a human trafficking issue with opiates related into it. So it's certainly something that we're coming across. The goal of the CIT and really of the clinicians would be information and referral, working with local partners, referring to, like I said, already existing programs. Whether we choose to fund these programs additionally with our opiate money, these programs do already exist and do already have funding, and they're running successfully, and they're running great programs. So we can keep supporting those programs and keep making referrals that way and try to partner with them. We can do on-the-spot brief counseling, we can do crisis intervention work, we can do follow-ups. Like I said, we're planning on doing live in-person groups, and then there's options. So if people would prefer not to work with us because we're associated with public safety, or because they're already working with so-and-so down the road, we're happy for that, and we're happy to still try to make those connections and leave information should there be a time that they do want to work with us. So it's not to say we would still be the only game in town, but I think it is more of a holistic approach, like Tom was saying. So if we do fund a second clinician, it would allow for more timely follow-ups with post-overdose survivors and individuals experiencing any type of opioid use disorders. Like as it stands now, I feel like we are, like Chief Grace said, we're doing the best that we can to do some of these follow-ups, but I think adding that additional person would kind of ensure more timely follow-ups and better communication within the department.
And when I talk about the overdose and follow-ups, dating back to 2017, Foxborough with connected, I believe at this point it's statewide, is if there is an overdose in any community, with opiates, you enter it into a state database. If it's in your community, there's a follow-up guide. If they're a resident from Foxborough and they overdose in another community, we get that notification that morning. We then initiate a follow-up, but that requirement of using a soft police officer until we had Christina hasn't really been as effective, because many times we would do the follow-up, we would do our best to maybe notify a parent or sometimes the individual to see if they were interested in services. I mean, we'll do anything. We'll drive you anywhere across the state, because that window, that small window, that's your golden opportunity when someone either walks through the PD asking for help or just got released from the ER. That's our window. That's our save window. And many, many times we find people who have no services. They have no connections to services. They don't have the ability to have mass health. They don't have anything in place. It overwhelms them, and we lose them. What we've noticed, having the clinical social worker who stays with that person, stays with them, enrolls with them, gets them into programs and funding and resources that are already in place. We just haven't been able to find the bridge, the person, because giving them a phone number or a website is not doing the job. It's passing the buck. I call it a bumper sticker. We put a bumper sticker on, it looks great, it drives down the road. We didn't change their life in the moment. Currently, what we're doing with Christina is she's there all day. She's there all day. If she needs a ride to somewhere else, and she has a list of every single open bed that day, we're doing whatever it takes all day if that person wants help. And that is time consuming, and we're falling short because Christina is also tasked with all of the other mental health calls and follow-ups on the domestic violence and the fire side of the elders who are challenged with some of the many other issues that they're having. We just only have one person, and one person can't do it all. So a person solely trained, licensed, and specializes in substance abuse is a game changer for us and for the residents of Foxborough, because these are the people we're going to. These are our residents, and we're going to their home. And we're talking to parents who have just been notified for the first time that their child has a problem, they need someone who's trained in that moment, in that crisis, to give them a roadmap about what's ahead of them. And a website and a phone number from the ER is not it.
So,
Christina, I'm sorry.
I was just going to ask for a clarification. We heard earlier that a lot of our cases that we see, due to the nature of how the town's set up, are, coming from maybe the area of Route 1, maybe, from trafficking or all these, non-resident avenues. And then, so if these folks who are transient don't live in Foxborough, we get those initial calls, those initial cases, but then we're not following up with them because they're not from Foxborough. So how many Foxborough residents are you guys actually following up with? Because it doesn't seem like those are the same follow-up cases.
No, I think that, just
Go ahead.
because I made the statement, no, I think we try to follow, it's a lot more work to get somebody that's here in a transient nature. We still try to do the follow-ups, we still try to do the interventions, and there's other things we can do too, in terms of human trafficking and things like that to kind of mitigate some of that, but I think it's different work than going to someone's home, and I don't want to speak for you,
It is. So we're still certainly following up, and if they move out of town, then the great news is we have a lot of resources. I'm networking with a lot of other clinicians who started working in their public safeties and other programs that accept people outside of our town. So we're still doing both. And then I think the other piece that this, potentially opens up the door for is just more bandwidth. So right now, just as one person, we can't do as much outreach and education to the community. But what we would like to do with our unit would be to kind of get on a road show and start doing presentations to our local hotels to give them tips and tricks, what to look out for, how can you help them, can we hang these flyers, can we hang these brochures, is there any way that we can start getting to the problem before it even arrives, if so to speak, and how do we support those people? So that would be part of these efforts as well, as providing education to local businesses and hotel owners, working with the schools to provide more education within the schools, and then ideally even within public safety, having that bandwidth to do educational programs and talks with both the police and fire in terms of best practices, what do we do on these kinds of calls. So I think if that could speak to that question a little bit more.
I think the profile, the demographic of the patients we're treating has changed dramatically in the last. So I started in EMS over 32 years ago, and I spent over 23 years in the emergency department, and I've seen great differences now. 10, 15 years ago, 20 years ago, 25 years ago, it was heroin. Now we're looking at fentanyl, looking at drugs that are contaminated with fentanyl. So the classic profile of someone where you think maybe suffering from opioid use disorder is no longer the same, and we're looking at these complex patients now who have a lot of different cross traumas, whether it's sexual assault, domestic violence, whether it's housing instability, whether it's maybe somebody who had a surgery at one point and then all of a sudden now is using illegal substances. So the profile has changed quite dramatically, and I think that is kind of what we're looking at in terms of how we follow up with these patients. The nature of some of the responses that we have emergently are along the Route 1 corridor, because in those folks that live in Foxborough, they just live in some of those units. So they don't live in maybe a suburban town, they live off Route 1. So by being transient, I think that they a little less stably housed than maybe somebody who owns a house on the other side of town, because that's the nature of that kind of population that lives there. They can be more mobile at times.
And we should be clear, our issue in Foxborough is not the hotels. There are people in neighborhoods,
everywhere.
streets, everywhere. This is not just, it's a Route 1 issue. That is not the case. Absolutely not.
Christina, can I ask you what your percentage of your caseload is dealing with opioids or?
Sure. Later in the slides, we're going to get to some of my data. I'll be frank with you. It's rather low. I've responded to 3 overdoses this year with public safety. So in the grand scheme of things, it's a very small percentage of the overall cases. So I'm not really sure what the exact percent would be, but you're going to see a graph. It's just a bit of the pie.
So how if your caseload with this type is low, you don't have to tell me now, but during the presentation, how would extra funding and an extra person help with?
Absolutely. That's a great question, Robin. So essentially, the funding would help with more of the follow-up efforts. So the police are going on their own follow-ups outside of my work hours. They're doing their work in that way, trying to connect me with more local Foxborough residents. But it also increases the bandwidth for, like I said, running those programs. Right now, I don't have the bandwidth to run individual groups, nor do I have the passion to do group work. So I think it's important to find the right person for that. We have the bandwidth now then to, like I said, go and expand, do a roadshow, do the outreach and education piece to try to educate some of these other hotspot areas that we're identifying in town and to work more closely with the schools. So although that number is low, I think, and also in reality, I'm not tracking exactly whether or not these calls come in. They may come in with a more mental health flavor, right? But there is substance use at its core. So I think it also depends on how we're spinning the numbers. A lot of my numbers are coming in as mental health, but I am working with a lot of people who are duly diagnosed with mental health disorder and substance use disorder. So I think, though, the overdose number is probably on par with what we're seeing over the last few years with fire and police. But in the grand scheme of things, I think the substance use disorder tracking is tricky because a lot of my calls come in as mental health, and it takes sometimes weeks to even uncover that there's substance use disorder at the core.
Does the data then change you were talking about a data-driven approach for all this? Does the data then change once you've learned that?
That's a great question. At least right now, it kind of comes, the way I track my data is how I get the call. So if the fire department's calling for me to go out and it's that nature of that exact call. So a lot of times those calls still come in as a mental health crisis, even though, let's say, it's methamphetamine at the core. It's coming in as somebody who is having paranoid delusions, so I'm treating it as more of a mental health call until we can kind of figure that piece out. So I think additional resources and funding would also help in terms of better tracking and I think improved systems for that as well.
Thank you.
What are you using to track your cases?
So it all looks a little bit different. I'm using in a pre-populated Excel spreadsheet that I've received from Advocates, which is a really large company that's doing the clinical work like I'm doing with public safety, but then these guys also have their own tracking.
So right now, the police public safety is in the process. We've had our current record system. It dates back to 2002. We start in 6 weeks on the new system, which fire is already on. And once that occurs, we're going to be able to put in for calls for service, multiple reasons for call for service. Right now, the CAT system allows one, and it only can be entered in by the dispatcher. So if it sounds like a disturbance, it comes in as a disturbance. Then as we show up and we find out what's going on, it may have changed several times, but we could, in the future, we'll be able to add that there was a disturbance, there was, other crimes involved, and we'll be able to track those secondary calls, which we can't track right now.
And how is this, how is it different, or what's the overlap from what we're getting from the state and what's state reported from our data, or is it the same? Are we assuming that it's all the same that what you guys are reporting?
I would say that our CAD system is not connected. I know it's not connected with the state whatsoever.
Okay.
So there's about 300 different CAD systems throughout the state. I'm not sure where the state is getting theirs. Those numbers on the overdose numbers, they may be reported from hospitals or from fire.
So we have a emergency medical services database that reports to the state, but again, it's whatever the clinical impression of the paramedic is at the time. So again, if it's a motor vehicle accident, the person behind the wheel was on drugs, it's going to be a motor vehicle accident. It's going to be trauma. It's not going to be the secondary. So some of that data might be.
Yeah, the primary and secondary impression, much like with COVID, during the COVID numbers, was it COVID-related death, or was somebody had stage 4 cancer, that type of thing. You didn't really get that until you disseminated through the facts a little bit. And for emergency medical services, when you think about the clinical aspect of the healthcare system at the ground level, the clinical aspect of public health even, our paramedics respond to quite a few opioid-related. Now, opioid-related doesn't necessarily mean overdose. Opioid-related can be just an impairment, it could be a disability in daily activities. When we look at opioid-related, our paramedics respond with advanced life support capabilities. So if we work an overdose, let's say we have someone who used an opioid and they're no longer breathing. Opioids depress the central nervous system and basically cease breathing. So our paramedics would arrive, establish an airway, ventilate for a patient, and then give Narcan, which is an opioid antagonist. Opioid blocks the receptors that receive the opioid and thereby allow that person to resume normal central nervous system functions, such as breathing autonomously. Now, the problem with Narcan is it has about a half-life of 90 minutes or so. And so we worry about, law enforcement is very integral in this part. If we have someone who now we've reversed with Narcan, number one, we worry about withdrawal symptoms. Now, withdrawal symptoms can be quite debilitating. They're not as lethal as maybe withdrawal from alcohol, but opioid withdrawal is quite uncomfortable. About 5 days of massive GI upset, sweats, diaphoresis. It can be very, very uncomfortable, and it's very prohibitive for someone who's suffering from opioid use disorder to want to come off of that because the symptomology is quite stress-inducing. So our paramedics would administer Narcan, but they administer it in low doses. We usually administer between 0.4 to 1 milligrams, and we titrate to effect to make sure that we just get a response and respiratory seizure, but we try not to put them in withdrawals. Recently, the Department of Public Health, Massachusetts Office of Emergency Medical Services has released an option under medical direction, which is called buprenorphine, which is basically the medication that's in Suboxone without the Narcan. So what it does is a substitution therapy that abates withdrawal symptoms. And this is something now that paramedics can administer to patients who are in acute withdrawal. So we really do a really nice job. I think our paramedics take a really great approach when dealing with people, and they give the minimum dose of Narcan. But what happened now is even the Narcan we're talking now for broad dissemination through the community, it's 4 milligrams and 0.1 ml. So it's a very small amount, very concentrated. So you have patients out there in the community now that are on methadone, Suboxone, which is substitution medications, as well as opioids that are not prescribed, and they can have significant withdrawal symptoms from such high dosages of Narcan at once. Ironically, we're seeing the greater need for an increased amount of Narcan in some of these patients. In the ER, I've had patients who have been on continuous IV drips of Narcan to abate some of the opioid effects. And what we're also seeing, and Chief Keller can attest to this as the leader of the hazmat team, we're seeing these drugs cut with a number of different agents. So xylazine is one of the premier drugs we're seeing. It's a veterinary anesthetic or sedative that we're seeing now mixed with fentanyl, causing a profound respiratory depression, and it doesn't respond to Narcan. So our paramedics are having to address airway issues on the way to the hospital in terms of bagging someone or intubating someone to maintain respirations and ventilatory status. So I think with this is a small portion of what we do in town in terms of managing patients, but it's an important point to help facilitate not only the acute care, but to open the door to long-term therapies. And Christina and I, we do multiple home visits a month. In following up on some of these patients, where I'll do a clinical assessment and Christina will do the psychosocial and offer services, and we try to bridge the gap and connect with the care teams, which is the biggest problem right now we're having is trying to address some of those gaps. And I think we talk frequently with the police, but I think if we had someone who is in the core role of this, specializing in substance abuse, that we can be in a prime position to kind of make more of a three-pronged approach. So, like I said, I spoke with Caitlina with JSI, who is the harm reduction specialist, and again, she discussed ways for cities and towns to use the abatement monies and how they can come up with innovative approaches. And again, she stressed there's a couple different tenets to this: is that you can't use monies for established programs or programs already funded. That you want to take into consideration town survey points, which I think is very, very important. And she really focused on harm reduction. So when we look at harm reduction, I agree, we can get Narcan out pretty much everywhere. That wouldn't be a problem. I think with EMS, there's also a protocol which we'll touch upon called Leave Behind Narcan. So let's say we go to someone's home and that particular individual had suffered an opioid overdose, resulting in maybe impairment to the point where they were not able to protect their airway. We could give them Narcan, reverse the opioid, and then if they were to that point being alert and oriented, refuse to transport to the hospital, we could leave behind Narcan with instructions. Now, this would be a little more complex than that. We'd work with medical direction. We'd also work with law enforcement who has the ability to PC someone, because generally speaking in the ER, if we had someone that was an overdose on opioids, we'd watch them for 3 hours to make sure that they didn't have a relapse and required additional Narcan administration. Again, the medication-assisted treatment expansion. Now, this is something we could look at funding programs for the buprenorphine, which is a new program that just came out. And again, this would be something we work with our medical control physician at our city hospital to get oversight on that. The harm reduction, education, and outreach. I think Christina touched on this a little bit. Again, she's doing a lot of this just organically anyway in the community, but this would be a more structured approach to community support groups, a very targeted outreach education program as needed. We've also received 500 fentanyl test strips, which we want to incorporate, which we've begun incorporating now. When we respond to issues where there's opioid use, we could actually leave the fentanyl test strips behind in English and Spanish instructions, so that if there was ever a substance that they were using that we couldn't tell. We've had several instances over the last, I'd say, 6 to 8 months where I've come across a substance, we weren't really sure what it was, but maybe if we left something behind, someone would be inclined to use it, and within 5 minutes you'd know if it's contaminated with fentanyl. And then again, the support services and recovery, which I think is something that Christina has worked collaboratively with the Council on Aging and Human Services and the school department nurses and social workers already. This is something that we could expand upon. Just to touch on, this is a law enforcement issue. So to address some of the issues that may be concerning law enforcement being part of a crisis intervention team, Chapter 94C of the Mass General Law, if someone is overdosed or seeking therapy, they cannot be prosecuted or will not be prosecuted legally unless there was a large amount and it appeared that they had the intent to distribute. I don't know if Chief wanted to follow up on that.
Yeah, things have changed drastically with heroin use overdose. There was a time if you were knowingly in a vehicle or in a room, you were charged with possession of heroin. That law is gone. That's off the books. I can tell you our agency is about a save. Unless, of course, we have someone who is distributing, unless we have large amounts and we see an immediate investigation that has to occur to stop this activity. But I would say the majority of all of our situations, we see personal use, and then we get called for someone not breathing, not responding, or altered, which is, we're seeing more and more of that, of someone who appears altered. Can you go down there and we find out what's going on? Our job at that point, we are purely looking from a medical standpoint and a mental health standpoint and resource treatment based. We are not looking to arrest people who are challenged with substance abuse issues. So years ago, we couldn't even put a person who was under the influence of drugs in protective custody. We did not have the legal authority. We literally had to let them walk away. And that has changed, just like as Tom was saying, if we had someone who refused treatment after being, I call it a save, and we just really felt, based on the medical information, that we really can't leave this person. We can't. We can PC them and force them to the hospital for treatment, not to the police cell. Let's make sure we're very clear on that. That is the last place they're ever going with the substances in their body.
I've already touched upon the leave behind Narcan. This is statewide treatment protocol 6.13, so this is an option for us that we could leave instructions in Narcan in a clear bag in the home for use. And I think a lot of this is, geared towards family members to be empowered to respond and help. And again, the buprenorphine, which is substitution therapy. And again, mental health, the Substance Abuse and Mental Health Services Administration says that even patients receiving buprenorphine at lower doses cut their death risk in half. So if we can mitigate some of those withdrawal symptoms, we have a better opportunity of getting these people into therapy. So over the last 5 years, here in town, we've had 197 patient interactions that were opioid related. And that doesn't necessarily mean that there were overdoses. That just means that there was an opioid involved. 96% of those resulted in transports. 3% were not transports. 1% were other, and that usually is DOA. And we've had 37 Narcan administrations in 5 years. So acute reversals that needed to be responded to by paramedics.
We kind of dive into the data of my role. So I'm the co-response clinician or the community social worker, whatever you want to call me. But so my data for fiscal year last year, I started basically right at the end of February. So really my data starts in March of 23 into December of 23. 796 total interactions. So that's basically, it doesn't mean it's a full-blown visit. It could be a phone call. It could be coordination of care. But essentially, I am documenting every point of contact at that in that state. So there was 222 unduplicated interactions. So what that means, those are unique individuals. So I met with at least 222 strangers last year to try to get them services, and that resulted in 796 interactions. So this year, this is right up to the end of August data. We're basically on trend to pass last year's data with 744 total interactions. I think today I looked at my spreadsheet and I had close to 780 some odd interactions, and then 207 unique people that I've met so far this year. So I think those numbers are pretty staggering when we're talking about unique individuals. I think, especially in terms of the workload that goes into this, some of these people, I want to say about 60 or so were one-time interactions. 60 individuals were either a phone call with resources or they maybe didn't want to follow up, but the rest of those people were all ongoing case management to some extent. Some people I've been tracking for over a year. Some people we work intensely for a couple of weeks until they get back on their feet and they can check back in as needed. My referral sources are kind of primarily through public safety. Much of my calls are through the police, mostly because they are in the moment calls where we're responding to mental health crises, which then we find out later on what was at the root of that cause, right? The fire department is about 16% of my caseload, which is pretty on par with what it was last year. A lot of those are failure to thrive in the home, needing additional connection to resources and services. There are fire-related incidents where we need to help support the victims of fires. More medically complex cases that Tom and I will go try to address in terms of getting resources and services. 16% of my referrals have been through members of the community, whether they're through loved ones or whether it's like the health department or the library. I haven't been capturing those specific data sets. 16% of them have been direct referrals, so self-referrals, people just calling me because they found my number through a friend or online. And 2% of these calls are human services related, where we have some overlapping clients with the social workers over at the Council on Aging, because they do a beautiful job over there, and we can't thank them enough. They have 2 great social workers that work primarily on case management, so that's helping with benefits, information, and referral. I also have that kind of experience, but we just do not have the time that it takes to get through some of those applications, like a mass health application. There's multiple follow-up appointments that need to happen in real time, in a fast time, to stay on track with their deadlines. So oftentimes I will refer those kinds of cases over to human services so they can get that bit of case management to get those benefits going. And then I'll work on the specialty benefits, like the mental health supports, whether it's finding a detox, whether it's finding a treatment facility, and we'll try to kind of come together on some of those cases. So this is kind of the call breakdown. This is where we talk about different kinds of cases. So there's, I think, like I mentioned before, the data is not exact, right? Some of these calls, a lot of these follow-ups are marked as follow-up because I'm working on them with the initial call that came in. So the follow-ups really could kind of get broken down more into the medical, the domestic, the substance use category. But as it stands, this is kind of how we're catching data right now. And I think we aim to improve and try to get more real-time data and more accurate data is exactly what the call is reflecting at the time. But the CIT would adopt a team-based approach. We would try to cross-train, and we would try to capture this data in a better, more holistic way where we can present it and have a better idea of exactly what the nature of the calls are.
So this is a journal article that came out in 2022. This is the Journal of Public Health Management Policy. Basically, it's talking about a co-response model that they're looking at for post-overdose outreach, the POST team, which is out of Boston Medical Center. And I think that this demographic, the numbers here are larger than we have in Foxborough, but I think it's very promising that, losing real-time and county-level data, monthly peer sharing calls with program sites and annual site visits, the POST initiative can really provide evidence-based practice recommendations and lesson learned. And I think if you take that concept of a team that goes out post-overdose or manages somebody with opioid use disorder. And again, there's a lot of overlap. As Christina says, sometimes it's not as clear, but then when you find those people and you're able to intervene in a way that may not seem directly apparent in the initial call for service, I think by enveloping that full circle empirically, I think you have a better chance of seeing a positive outcome. And, there isn't a lot of data because these interventions are very new. Other parts of the country have spearheaded teams where they have nurse practitioners, peer social workers, firefighter paramedics that go out in soft clothes and respond in the community. And I think that's something we're endeavoring to do here for the people of Foxborough. And again, just to follow up on some of the JSI resources, again, Kate provided plenty of great resources, very thoughtful emails in terms of access to information for us. The Pronto study was one that BMC has been doing well for post-overdose. And looking at, potentially using settlement funding for a specialized clinician in substance abuse disorders. And again, one of the recommendations was SHIELD training, which Foxborough Police has already engaged upon in terms of giving a curriculum and training on better providing access and interactions with folks who are suffering from opioid use disorder. So I would say in summary, the creation of a community impact unit is it's definitely something that's under the purview of the abatement monies. I think it's a forward, innovative, or thinking approach for the town of Foxborough, specifically for the town of Foxborough. We'd be incorporating clinical social workers, EMS, law enforcement, the health department, and by social workers, we also mean our colleagues at the Council on Aging, Human Services, who are an integral part of all of this, as well as the school nurses. We collaborate quite frequently in a number of different things, so this is an extension of that. But we've been bringing this together under a more holistic community approach. And again, we want to try to reduce any redundancies and have this be the central hub of outreach support groups, education, harm reduction strategies, and then response capabilities or referral for services.
Thank you. I have a few things. One, just, what is it called? Housekeeping-wise, just frankly, it would have been really cool to get this ahead of time. I appreciate the presentation now and that it's going out to everyone live. But I think it did address some of our initial discussion and concerns. So thank you very much. I think the holistic approach and a multi-pronged approach is a good one. It just matter how we get there. I do have a question in regards to the schools. You mentioned the education of the students and how's that gonna, what programs are being run now? And my understanding is, if this is correct, they are going to be sunsetting interface and then replacing it with what? Is that with this program, or how would that work?
I can take the latter half of the question if you want to take the first half.
As far as the school and education, Tom and I have already been in the works with meeting with a woman from a program called Achieve Greatness, and it's about her son had passed away of a fentanyl overdose. So we're already working with trying to bring kind of education programs. I think one of the biggest things Christina kind of touched upon was this preventative piece, right? Using this money for education and using this money for families. When there is someone in a family that has substance use disorder, it affects everyone in the family, and we're trying to help the whole entire family, doing that like wraparound services. Working in the schools, I'm so fortunate to work with all of these amazing people. Foxborough is fortunate to have these people at the head of all these departments, and it is such a collaborative approach. I've been here 10 years in Foxborough, started as the nurse leader in COVID. Tom and I became fast friends, best friends, continue that collaboration. Christina has done amazing work with the schools, collaborating, but she's one person. Right. We need more bodies. We need more boots on the ground. I think that was a big theme that's been throughout the evening. But as far as education, we're definitely for that. We have a wellness committee. We have a wellness committee director in Foxborough who does amazing work. And this is part of this year. One of our goals will be to bring these kind of education programs to our schools.
Excuse me, is Achieve Greatness, is that just somebody
It's a
coming
foundation.
into an auditorium?
Yeah, it's a foundation.
It's not is it like an auditorium presentation one time?
Yes, yeah.
So it's not like
No.
classroom.
Right, exactly.
No, but I think
But
it would be
they're-
teasing those pieces out. So I work closely with Amy, who's also one of the wellness leaders in town. So I think it's just figuring out what the curriculum looks like as it is, and that's something that we haven't exactly, her and I haven't had the time just yet to sit down to say what's already being done and what needs to change, what's not working. And then I think getting new speakers in and trying to figure out how do we better utilize, if there's time in health class to start working on some of this, or is it an after-school program? So I actually just started having an intern working under me, and we're going to start working with the library in terms of supporting some of the at-risk youth after school to run some type of healthy support group there. Right now, I think we're going to focus on healthy dating, but I think that could easily transition into, other healthy coping skills and when to say no to kind of things, and I think that would lead itself into some of that. But I think we need to nail down a little bit more how can we best affect this at the school level. And then in terms, I want to address, Sophia, that piece about Interface. Interface has been a great tool. So I don't know, for those who might not know what Interface is, it's a program that we pay into through William James College. It's run by interns and faculty at the college, and it's a concierge service essentially to finding a counselor. So you call in and you say, I'm suffering from, I have some anxiety and a little bit of depression. Here's my age, here's my gender, here's my health insurance type. I live in the town of Foxborough. We subscribe to your services. I would like to meet with a female only. I'd like to meet online only, and I'm only available on Mondays. Mm-hmm. And they go through their whole database and they pop out 3 or 4 names of people that meet that criteria and should have a low wait list. It's been a great service, and when we started using that service, there was nothing else like it. At least that we knew of. But recently, through COVID, the state has realized what a time we're living in and how much more service and support we need. So they actually made a behavioral health helpline. It's a 1-800 number. You can call, text, 24 hours a day, 7 days a week, including holidays, which I think is huge. So William James College only runs, I believe it's like 9 to 5, Monday through Friday. No holidays, no nights, no weekends. You can't text. Can only call in English. You need a translator if you wanted to call and speak in another language. Behavioral health helpline, they can translate up to 200 languages. They can do American Sign Language, and you can text. So that's been a game changer for my youth that I'm working with. I've worked with a lot of different counselors in the school who are like, I've already given Interface 2-3 times. They haven't reached out. What do we do? So either I'm calling with them, because that's what I do, or I'm giving them this line and saying, why don't you text them when you get home? And then you can talk to mom or you can talk to dad about what health insurance you have and get to the next step. So the behavioral health helpline is free. Right now we're paying, I don't quite exactly have the number, but it's 30 some odd thousand annually for William James.
Which is coming out to $300 a phone call.
Yeah. So
Essentially.
What kind of, that's what I'm saying, if you're phasing something out and this service is free from, one more time, is it the state?
The
or is
state,
it-
yes. So the state's rolled that out. It's about 1.5 years in the making.
You get statistics from the state, like
So
how
I've
many-
emailed. I'm waiting to hear back. I hadn't heard back from my contact just yet. I emailed her last week. So I do believe it's the state. They're definitely capturing the data. It's just, will they share the data? So it's nice that William James puts out this beautiful report, which I have handy if anybody wanted to take a look. But that is something I wanted to just to get to the fine, put a pin in that. And just so for your records, 3 of the 54 calls in the last quarter that was tracked by William James were substance use related. So I think that's trending with about the population that I'm encountering right now. Not to say that it's not a fine number, but again, it's how we track it too. I think a lot of people are calling and maybe that's in the background, but they're presenting with an anxiety or they're presenting with a depression. So the idea would be to maybe not use some of these funds to refund William James. I think it's been a great program. If we can find the funds maybe somewhere else, that would be ideal as well. But where it is a redundancy, where now we have behavioral health helpline, and I think it's honestly a little bit more accessible. I think both give a good product, but William James is very costly, and I would say that out of the 52 or 54 cases they're telling us we referred, 22 reported that they did get connected to a provider. 21 callers did not get connected. 3 callers decided to pursue services kind of on their own. And then we needed to, I just want to circle back. 5 providers found that they found somebody on their own, and then I wanted to say it was a number of 12 providers that
Repeat callers.
were repeat callers. So I don't know that that's a great number to.
Well, we get the gist.
Yeah.
I was just curious about the program, if, again, being sunset
the
versus
difference were.
what's replacing it. And it sounds like you've got two-pronged things happening. The public safety updating their 22-year-old, I didn't mean to giggle at that, I'm sorry.
No, you're fine.
22-year-old system to offer, you said multiple check boxes of kind of coverage of what kind of calls they are. And then one more question in regards to this new role, or if it's a singular role, or if it would, and how it would be funded. I don't know if anyone else wants to tackle this, if I'm jumping ahead, but.
Go ahead.
How it would be funded with, is it a full-time position, a part-time position, or would you consider two part-time peer-to-peer type solution, counselor solutions and stuff like that? I'm just curious about what the presentation as of like a super team, kind of like a CIT, I'm sorry, this is a community impact unit.
I like super team.
You can call it super team. Let's not call it Avengers, that would be too weird. But there's, is a good starting point, and not honestly what we were thinking about when you said social worker. We're like, well, that could be too generic.
Right.
But what thoughts have you been put into, or if it's a job opening description already for the said social worker, peer-to-peer counselor, et cetera, if that's been opened?
Do you want me to talk? I'll talk about that. So just from the budget perspective and based on the numbers that the town is receiving on the settlement, there's been a cost analysis done by the finance director stating that until we have full funding of a clinical social worker, similar to Christina, probably not as good, but she's awesome, to the year 2032.
2013.
Sorry.
2030.
2032. I'm
was
getting
like,
old.
wow.
Hold on. I don't have my readers, and you got to see this. This is terrible.
2032 is fine.
So 2032, we can start FY '26, and we're fully funded. At that point, we then have to look at the dollar value for the next 6 years till 3038, and as the salary increases, someone will get a raise. Then we would have to allocate within the public safety budget to supplement the difference. But it does give us a 5-6 year window budget projection to plan for it.
And would that cover the, I'm sorry, is anyone else having? I'm commandeering. And would that cover the entirety of the funding from the state versus you did mention the multi-pronged approach here in regards to obviously the EMS and harm reduction. So how would that filter out through that as well, or would that be taken from your budget?
No, this would be that one position. So we wouldn't, eventually, I think if we were to kind of continue the position, I think it'd be a combined effort between the two departments.
So
Right now, all those people already exist and those programs are already kind of running. So I think it's already existing infrastructure in terms of that. It's just adding one more clinical social worker. So I myself would still be part of the team, and then there'd be somebody under me, essentially, whether or not they have quite the same licensure or not. But I could kind of direct that approach, and then it would add in terms of our coverage. So we would talk about covering separate shifts. We talk about maybe weekend coverage, because right now there's only 40-hour-a-week coverage clinically with myself.
So when Christina goes on vacation, we have nothing in town. Essentially, when we have some of these calls for service, looking for a clinical social worker, because relying on third parties, they're just not available and they don't come out in the moment. And sometimes we're sitting 2 hours, 3 hours trying to get a clinician to help the family. So Christina's been handling almost all of them, except for when she's just physically not available.
So I have a few questions.
Yeah, no,
Are you-
please.
are you-
I think I've done enough. I've asked enough. You can go ahead.
So have you thought about regionalizing this? So if you only had 3 cases this year, if you had 4 other communities and everybody put in money, then we could have some other money for some other programs.
So can I talk about that?
Yeah.
So this model is actually going to address the calls for service that we're having with the immediate opiate overdoses. But as been presented, almost all of our cases also have another element to it that is just sucking all the time. So this clinical social worker will primarily focus on the opiate issues, but then, because of their license, will be able to help with the other cases that we have townwide as well,
And if
with the off hours and the weekends.
And if I could talk about the regionalization aspect, I think it sounds good on paper, but what I'm seeing, and with my position, a lot of these co-response units have popped up. I think there's about 100+ towns in Massachusetts that participate in co-response, and they've tried regionalization, and what we're seeing now is the chiefs are getting calls. How do we get our own social worker? How do we pull out of this third-party contract that we're in? How do we kind of lock it down so it's kind of controlled within our town? So these regionalization I think they're great, but I think it also leaves a lot to be desired, where one town might benefit more, or one town might not like the protocols that the first town set forth. So I think I'm seeing a lot of these programs kind of, unfortunately, go by the wayside, or they're having to reinvent them and hire their own autonomous person. There's been a couple recently that have just pulled out of their third-party contracts that were part of 2 or 3 towns, and started to hire within. So I think
Yeah,
it's...
I was thinking about it for not all different social work cases, but just.
But just the substance
but just
use,
for
right,
this. And we do work with other communities on a lot of other public health
right.
programs, and it is working, so just so. And then the other thing that I was going to ask you, one of the things that we were intrigued about is having recovery coaches in town, as opposed to a social worker from the public safety department, because there might be some people that need help but might not want to go to public safety. And then our recovery coach has different skills than a social worker. Have you thought about that? And
Absolutely. So I think that's where the partnering with these already existing programs come in, because I don't know, I'd really be curious to hear from you guys if you've heard of agencies that have specifically said, if you give us funding, this is what we're going to give back to you. I think we've heard of a lot of great groups that are existing that would like some additional funds, but I just haven't quite heard like how that's going to be Foxborough centric, if that makes sense. So I think I've already gotten great relationships with New England Medical Group. I'm working with one of their recovery coaches who's a peer and an advocate and sponsors individuals. So I think getting like a Rolodex of these kinds of individuals, Rockland Recovery is another agency I've been working closely with who have peer recovery people who I think would be willing to partner with us.
But how would they be funded then?
How are they funded? Some of them are doing it out of their own, on their own time. A lot of the peer coaches and the recovery coaches are, really committed to helping others in their journey. So a lot of it is free speaking. It's taking on sponsors. I would like to work like closely with an agency like Turning Point, if it's not Turning Point. But those positions, those groups are already funded either through the state or through insurance. So I think it's just kind of getting a more beefed up Rolodex of who do we call and when, because I think that's a lot of what social work is too. It's just figuring out, well, I'm not the expert, but I know, Joe down the street, he's the expert here. Let's call Joe. So I think it is kind of just collaborating more. And then if we do these groups or we do any education and outreach, it's pulling those people into our team and saying, all right, we really need a speaker who knows about this today. Can you come and talk on that? And how do we get these people connected? So I think we don't want to take away from any of these great groups. I think we want to work with them side by side and kind of share referrals and things that way.
And then we were thinking of having a curriculum in the school, but then we thought that the schools already have a curriculum. Is that true?
So it's part of the health classes. They touch on substance use, drugs. They learn about that. And I know they just went through an update in the curriculum and last year, and it was approved. So they're already they do Senior Safe Choice Day every year, where they have people come out and talk about drinking and driving and drugs and use, and they have they use the goggles, the marijuana goggles, so they're able to see like how it feels like when you're impaired. So they're already doing those programs in the schools.
Quick question: are those, because I don't have kids in town, are those classes, can you opt out, or can parents opt out, or are they mandatory for every student in the school system?
I don't think they send something out if it, you don't get the option.
They would like to opt out of health class, but
Right,
Yeah,
it's
we
because
have-
it's a state requirement.
I
right.
just,
Yeah.
like I said, I don't know.
Oh, yeah, no, that's a good
Yeah.
question. Back to the, sorry. She said recovery coach, I was saying peer-to-peer, same idea. Is this, I'm just want to be sure that it still says clinical social worker, and I just don't know if it should be, I get, it's a centralized person who specializes, right? You're going to seek out a specialist in this, like through Mass Health or whatever, not Mass Health, was it Boston Public?
Boston Medical Center?
Boston Medical Center, thank you. Would they be the ones recommending, or you just go, it's an open search, or
For
for the position of a specialist?
Oh, it would be an open search. So, we would have a specialized job description that would kind of target what we wanted to see. And, excuse me, and hopefully we would get candidates that do have that background. And it's not to say that there also aren't people in recovery in professional jobs as social work. So I have a few peers that I can think of that I think, do the work in the recovery setting and are recovering and on their journey of recovery themselves. So I think those are kind of the people that you would want in your corner in these kinds of calls and doing that kind of work.
What do you say to when I had said that there might be some people that might not want to seek services in the town's, public safety, where they would
I
like to
think
seek
they
it?
said they were going to meet them at schools wherever they want to be met.
Yeah,
I think
so-
the
Well,
question
that's
is,
not meeting them, that's,
Yeah.
you're still dealing with personnel.
Yeah, so I mean,
Okay.
if they don't want our services, it's not to say that all of these other services don't still exist and it wouldn't be the same journey that they would have already been on, right? So if they don't want to work with us and we're out on the call, so typically that's when we start working right away. We're on the call. Let's say it is a post-overdose. We're getting them to the hospital. I can leave my card, but they're also going to get services and referrals once they go to the hospital, once they come home. So I mean, it's not a perfect catch-all like as it is now. I get a lot of clients who maybe don't want my services right now, but in a couple months from now, they may say, well, actually, I remember, Christina, you called me and I'm in a better place. Let's work on that. But it's not to say that it's a one-stop shop either, so they can still go and get some of those services. And I think that's the nice piece about having the social worker, where it doesn't have to be tied to public safety. I go out on calls myself. I don't have to take the police or the fire, so we could just go meet at Dunkin' Donuts or we could just go meet at the library. So I don't think it all has to be tied into public safety, but I definitely see where you're coming from in terms of that concern and how do we refer them. And I would say, maybe I'm not the right person to help, but I'd love you to call XYZ if you wanted to get some help. Or even the behavioral health helpline, which does specialize in substance use as well.
And what is everybody's comment on not putting all the money in one basket, but putting it maybe a part-time person, and then we could have, the monies to fund our shops program, which we don't have money left to do that, and to destigmatize this whole topic. We wanted to have some money available for that. How do you feel about something like that?
Well, it's a great point, and I think what we're trying to illustrate is that this team could be the focal point to affect a lot of that. I can tell you now that a lot of the sharps that are mitigated from opioid use are picked up by police and fire. The sharps boxes that are outside the COA are primarily for community use. A lot of diabetic needles in those sharps containers, but the ones that are being picked up on the street are actually being picked up by law enforcement and fire departments. I think there's a lot of ways you can look at this, and there's a lot of ways we can continue discussion on this. It's just one idea of how we can create a team that's innovative and creative in its approach, but focusing on Foxborough specifically. There's a lot of overlap that's already occurring now. There's a lot of coincidental, or I should say collateral regionalization that's already been happening with shared services. There's a lot of crossover between police, fire, EMS, and Christine has been requested by other towns. We're also noticing a lot of other towns around us kind of go towards this kind of model that they're all seeking out independent people to kind of focus on this type of care set. So I think there's a lot of ways you look at this, and I guess it all depends on what the community drivers are and what the need is. But having said that, again, there's plenty of ways to look at this and kind of hopefully come to a consensus.
Yeah, and I don't think you get this kind of collaboration on the communities. I mean, the police, fire, schools, I mean, we're all here together presenting an idea, so I
I
think,
think that's great.
Yeah.
I'm thrilled that you're all here, and what you're presenting sounds like you care and, you know, you want to solve the problem. But like you said, there is a lot of different solutions that, you know, we can look at. It is a lot of money, but it is, it's not going to last forever. And we wanted to make sure that we get the biggest bang for the buck. And we think that there's some other needs. And I also feel that the health department has a different perspective on public health for the community. And so I just wanted to make sure that they were included with education and the ideas that we put forward. Because, for instance, other towns have committees on underage drinking and substance abuse. We don't really have that in our community. And that's a form of education for parents, and a good education that would meet people different ways and how to deal with things. And we don't have that right now, and I think those are all different things that we should be looking at.
To add on to what Robin was talking about, my concern is that we are, it's a lot of money, but it's not a lot of money to last us for a long time. And according to your plan, with the CTI or the CIU unit, there are a lot of programs that can start, you know, when this clinical social worker begins working with us, and they can find gaps and help mitigate some things, and, you know, add referrals and add supports. But we also won't have any more funding to do any of those things. And my concern is that we'll exhaust all of our funding simply getting this person in town, and then when they need to do the work, we don't have any money to support them. We're public health, so we think about it from a health perspective, and there's times that we've wanted to do things within our department, and we learn different challenges, different health challenges throughout the town, and we don't have enough money in our budget. And that's not uncommon. We don't necessarily have the same avenue of receiving money. So I'm a little bit cautious to put the entire budget into funding this one person. I would be open to a split of some sort where half of, you know, maybe we fund this social worker partially, and public safety covers the other portion of it. And then we leave a set amount of money that's allocated for any future programs, any long-term programs, any supports. If we do work with different partners, whether they're in town or in our local, you know, whether it's in Wrentham, Foxborough, Sharon, whoever, because we do have collaboratives as well, and we are working with other towns. If they need support, we can help them, especially if we're referring people there or they're referring people here, and depending on how our communities are moving. Like I said, my big concern is that we're using all of this money for one thing. A social worker is a great idea. It would help us, but that's not the only thing we would need, at least, and that's not how we're seeing it from a public health perspective. So yeah, like I'm just one person on the board. I'd be open to a split and not a complete, you know, put the whole budget into funding somebody for 5 years.
So I think in regards to funding someone for 5 years, that is basically, that's going to get the program up and running, and then it's going to be on the fire chief and the police chief to continue that position forever. This is not 5 years and go home. And when we talk about hiring someone like a clinical social worker, if you might notice, there is an absolute shortage across the state, everywhere, for that position. And there is no decrease in calls for service coming. We're not going to find this magical time where we're not going to need clinical social workers. And we've also been able to, and we started to look into this, when you hire a clinical social worker, they also are capable of billing insurance companies. So we have potential, if we're running groups, if we're running individual therapy, we may be able to look at revolving accounts to supplement as we go down the road. We're also not saying that we may be able to get a DPH grant that may help fund this in a year or two, which would then allow us to free up some of the money back to the Board of Health. But that's all ifs, and you can't build a program on a dream. It has to be sustainable. It has to, and the board, the select board, is going to say, "Love your all ideas. How are you going to pay for it?"
Right.
They're not going to pay. I can tell you, if we.
And that's why maybe to have maybe a part-time person use the statistics that you have, show that, you know, this is what we were able to do, and, you know, we're going to need more. But I think there's other things that we wanted to do.
I just think as long as this doesn't preclude it, right? To the extent of, you could get to the percentage of what we would need, or if some of the other elements we were looking for are already covered by the thought behind this, I almost said CUT again, CIU again, in that the Narcan boxes or whatever, like, could exist, right, throughout town to kind of help your job mitigate. If people are, again, training, if you get you put it in the CPR training, you can help mitigate, ultimately let the citizens help mitigate part of your doing, you know, until you get there, to continue to help save lives. So that's kind of what we're coming at. If the harm reduction is already considered as part of this, is that already independently funded, or is it coming out of this as well? That's, I think, right? Is that some things we were?
So a lot of, and Chief Gallagher, police and fire, we're gonna leverage a lot of our existing resources and our budgets to make this work.
That's great.
But I can tell you, you can't make it with a part-time social worker, because the part-time social worker doesn't exist. A licensed independent clinical social worker and part-time, the job opens everywhere. We're not gonna get one.
Well, that's one of my questions, was when I asked how many, you know, cases, we're talking about. I think we have to, you know, show the need and then expand, rather than.
So the need is there for the social worker with public safety and the Board of Health. This is happening everywhere in town on our calls for service. As Christina said, she's going to be well over 1,000 calls. How many of those have a nexus to substance abuse is substantial. No. I just want to really, I've been doing this 26 years in the town, and there is nothing worse when you show up to a call for service, whether it be at 10 o'clock at night or a Friday, and what you only can give someone is a phone number. When you cannot have a body show up who is trained, licensed, and educated in the crisis that family is in the moment, who isn't going to walk away, who's going to disappear, who's going to be available when you get in your car and you have a question, you drive down to 8 Chestnut Street and they'll meet you, they'll be there. They're not going away. Many times people are in crisis and they don't even know what the roadmap ahead of them is. They have no guidance, and if you were to call right now your primary care and ask for a referral, good luck.
I agree with
Good luck.
No one's disputing that that's obviously the goal.
It's a crisis, though.
Yeah.
It's a crisis, and we're finding a way to plug the hole or fix the crisis for our residents.
Okay, so,
In all due respect, though, you did say that this position would also do other things.
Absolutely.
Okay.
All of the mental health, all of the calls for
be
service.
fair, but
there's a lot of, I understand that.
And a lot of the agencies, I think, that are looking for some of these funding also help other things. So I think we have to look at, that's a two-pronged approach too, that I think we're not ignorant to the fact that we would be working on other things, but a lot of these other agencies are helping, reduce alcohol use, reduce other things beyond opioid use. So I think even funding interface, they're primarily helping mental health. So I think everything is so interconnected in some of these calls. So I just think if we're going to look at it that lens, I think it's helpful to see both sides that way.
And our kids, like, I mean, all my kids went to here in Foxborough. The social workers at the schools are fantastic, but they're not on call. They're not available at 4 o'clock. They're not helping us with the charter school. They're not helping us in the summers. So we're making sure we stay with these kids for this gap from June to September. We're following them and their families.
Would this social worker be on call?
Absolutely. Christina is.
Yeah, so I'm on call, so it's definitely we would be able to make an actual on-call schedule so that there would be somebody to fill. So right now I'm on call, but if can't be on call 365, right? So if I can take the call, I can. So I think this would give us the ability to actually make a real schedule, so somebody would always be answering. We would get some weekend coverage, and I think, an additional coverage on the shift that I'm not working. So right now we're seeing a big gap in coverage overnights. So I think that would be, ideal to add.
And police and fire are going to leverage their budgets to cover it as well.
So we're going to open it up. This was a great discussion. We're going to open it up to some of the folks in the community who came up. If you want to stay in the front, you can, but we do need mics.
We would ask. We would ask.
Thank you, thank you.
Well, we
Thank you
ask
for
you
your
to
time.
stay as well, actually, if you don't
Yeah,
mind.
don't leave yet, but
Don't leave.
stay close by.
Thank you for the presentation.
Thank you so much for
It
listening.
was very thorough. Thank you.
Speaking of that presentation, will we get a copy of it?
We did send one out to the collaborative. I think, Matt, you had one?
No, I couldn't access it because it's behind a firewall.
That's why we didn't have it. Ironically, from the fire department.
Sure. If you have a comment, come to the front, state your name and your affiliations.
Okay, Steph McGowan. I live at 19 Rhodes Lane here in Foxborough. And, they're still here. I said they stole my thunder. I was going to say, and I agree, this is like the cream of the crop sitting here, for sure.
So lucky that we live in Foxborough.
Absolutely. So I guess the couple of questions I had, I should say I am on the Board of Selectmen. I'm speaking for myself. I'm not speaking for the board.
And we're glad that you're here.
So, but I wanted to come tonight and hear the presentation. Of course, you guys going to make some recommendations. So I guess a couple of the comments I had is everything I heard here sounded fabulous. I don't disagree with any of it. I think the only thing that's coming to mind, and it came from you guys, about putting everything in one basket. I wonder if, I guess only the chiefs could speak to if, when we're talking down the road a little bit, being able to, fund it or even do a partial fund at this point. I don't know. They would have to speak to their budgets and whether that's, possible or not. So I'm not going to speak to that. I guess the only thing else that I want to say was when Matt talked about the survey, I heard the word recovery. While I think this is all fabulous, the one thing I think here that didn't hit was the recovery part. And I understand the education is what we need, and this is where you have to start, okay? Which we'll come to. And listen, I'm not here so much to advocate for Gilly's house, but they did reach out to me, and they knew that the Board of Selectmen is going to be making some decisions. And so she said, well, do you want to just come and take a look? So I said, well, of course, why wouldn't I do that? So I guess where I think about all the eggs in one basket is, and I don't want to speak to all their accolades, but I was so impressed when I went there. I was actually shocked. I didn't really know what to expect. I'm sure most people will say, even if it's not directly direct your family, I lost two of my best friends, one to alcohol abuse, one to drugs, okay? And I know what they went through, and unfortunately, they didn't get to the finish line with complete recovery. But all of this is wonderful, except what do you do at the end? At the end, most of these people aren't going to just take the education and that's done, right? They're not going to use drugs anymore. They're not going to drink alcohol anymore. Most of these people need a place to go in between being able to be on their own. And while Gilly's house is not in Foxborough, they service people from Foxborough, and I think maybe that's where the state maybe gave the little bit of leverage to be like, okay, you don't have to spend it all in Foxborough. I do agree, like, it's if there weren't other places that we could spend a little bit of the money, then I'd say, of course, we want to spend it all here, you know, biggest bang for your buck. I don't disagree with anything that was said here, but I think it might be nice that, and even if it's, you know, I'm sure you're going to hate that I say this, even if it's not this year, that's why I like to see some of the money left, because, you know, I know they sent a request in for you. I'm sure they would take anything helps. I mean, I could not believe, as we went from room to room and she showed me, what the donations were: food, gym equipment, furniture, and we do need something, and we don't have a facility like that in Foxborough. So if people in our community need that little step before they're recovered, you know, so I mean, I don't know if anybody here, you're nodding your head, so I know you must know, or you've been there before, either one. You know something, if you haven't gone to see them, it might be a little too late right now, and, you know, while it may not be this year, I might hope that there is a little money left, so that even, you know, that there are some other really good places to put some of that money. And I agree, we want to put the biggest bang right here in the town, but that doesn't solve the whole problem. There's many levels to get to the end, and like I heard, recovery. That's what that survey said, recovery. For me, this, while I'm not going to say we shouldn't do this, of course we should do this, but it didn't hit recovery. And so I'm just wondering if, you know, I think not putting all the eggs in one basket might be the way to go. I know the chiefs don't want to hear that either. I would support this at, you know, if the town, you know, it needs to be budgeted. It's a problem, and we have to put money into it. So anyhow, that's all. I just wanted to give my 2 cents, and I look forward to your recommendations and hearing them tomorrow night.
Thank you.
All right, thanks.
Stephanie, are you not, I didn't think it was on the agenda for tomorrow night, is it?
Ooh, I think you guys are. No?
Interesting. Okay, we can.
Okay.
Oh, okay, I'm sorry. I happen to be the chair, and we worked on the agenda on Thursday, but I.
All right, 2 weeks then.
You guys were on.
Do we have a
Maybe
meeting
there
in
was a
2
switch.
weeks?
Let's just pass these around.
Sure.
Those are something that I give people that I serve. Those are Narcan kits. Hi, my name is Chris Long. I'm a resident of Foxborough, 4 Peni Terrace. I work for Riverside Community Care. I'm a recovery coach, advocate, and soon to be a peer mentor. I have 5 kids, 2 of which are in recovery. And like was said earlier, you know, I used to call the police all the time because my kids would come home high and I didn't know what to do with them. And the police would apologize because there was nothing they could do for them. It has changed. It has gotten better. But where we lack in this town is education. Education in the school system. I mean, I can read off a bunch of statistics if you really want to hear them. But at the end of the day, by the time our kids get to high school, they're already experimenting with drugs and alcohol. I have my 2 granddaughters that I've had custody of since they were 2 and 4. And one of them is now a sophomore in high school. But last year, she was a freshman in high school. And she came home and she told us about a movie that they watched in health class. And her interpretation of that movie was they showed kids drinking and using drugs, and then they showed somebody using heroin, overdosing, and dying. And we weren't notified. Like, guardians and parents weren't notified that they were going to show a movie that is relatively graphic in my point of view based on what she told me. But what she realized at 14 was that in the time, at the age of 4, she always thought mom and dad were using medicine. And that set off a whole bunch of emotions and feelings and questions. You know, her mom and dad are sober. They're doing great. It's just, they don't educate. And I can only educate as much as I can educate. You know, kids aren't gonna listen to their parents. They're gonna listen to other people. I recommend having a peer mentor in the school systems that visits the school systems, that's there for the kids to be able to maybe talk to, that will be able to provide resources if kids need resources. I know growing up, I forgot what they called them in school, but it was like a peer club. And it was strictly for kids that, you know, maybe have a mom and dad that are at home using drugs, and they don't know who to turn to. They don't want to go to the police department for fear of DCF being called and then, you know, all of that nightmare happening. I also feel that we need to provide better education for the families. I had nobody, and that's how I got into it. You know, I didn't choose for my kids to do drugs. My son was on track to be a Division I lacrosse player, had an accident and got introduced to medication in the hospital. And part of his story is he'll tell you he fell in love with that feeling and he chased that feeling. My daughter experimented in school, and at 18, her boyfriend put a needle in her arm and she fell in love with that feeling and she chased it for years. They both chased it for years. And I didn't know what the hell I was doing as a parent. I had 3 other kids that were younger at home. And I turned to the police, and like I said, and like they said, there was nothing they could do. And there really wasn't anything out there. Learn to cope was the only thing that was out there when this whole thing started. And I sat in that meeting for the first time with another mother from Foxborough who took me, whose son was also suffering. And I sat in that room, and this was a long time ago. And that room was filled with families. And the takeaway for me that kept me going back was at the end of the meeting, they do the serenity prayer. And Joanne got up, her son had shared his story. Joanne got up and she said, we're gonna take a moment of silence. There was a family standing at the back of the room, a mother, father, and a daughter. This was a Thursday night meeting, and on Tuesday they had lost their son to an overdose. And they were at that meeting on Thursday night because it was like-minded people. Now, I've offered Narcan trainings in this town. I've offered support groups in this town multiple times. If I could tell you how many people from this town have reached out to me because of being loud and proud of my kids and fighting for them. I do the flag display up on the common, you know, every year for the last 6 or 7 years, and those numbers, they went down this year, whoop-de-doo, but they're not getting any smaller. Each flag represents a life that's been lost to accidental overdose in the state of Massachusetts. I think there was over 17,000 flags on that common this year. We need to educate. Educate is the only thing that is going to help slow this down. This disease is not going to stop. We can't stop it, but we can slow it down, and you have to start with education. Family education, elementary school education, middle school education, and high school education, as well as support. I don't think a licensed social worker who should be, you know, set for opioid use, SUD, whatever you want to call it, AUD, doing other things is a good way of using this money. I also worked for an attorney on this opioid case for Purdue, and I took over 1,300 impact statements. And those impact statements are from dental, people that had dental work, medical, tried to stop, but they said, no, you're in pain, you need to let your body heal. Those things have changed. They have slowed down a little bit. You know, we've gotten better about med management, but we need to educate families so that when they go into an emergency room, and because their child has been hurt, and they're trusting of the doctors, and they're pumping them full of meds because my son dislocated his shoulder. He was 16. He had been on the ball field. He was full of adrenaline. He was fit, and he couldn't relax to relax his shoulder, so they kept giving him meds. And then all of a sudden, boom, he's in La La Land. And, you know, I trusted the doctors, and I didn't know what to look for. I didn't know that, you know, he could call the doctor and say, oh my God, you know, these Vicodins aren't working. I need something stronger. He was able to do that. Pills have a dollar value per milligram. So if you have a 30 milligram Percocet, Vicodin, whatever, it's a $30 pill. It has a street value. Gabapentin has a street value. These are things that parents need to be educated about. I needed to be educated about. I had to do it myself. Kids need support. They need somebody to be able to talk to. Like I said, I'm a recovery coach, I'm an advocate, and I'm soon to be a peer mentor. I'm taking the classes. There are services out there. There is support out there. We can do better in this town. Thank you.
Thank you for sharing your story.
Thank you
What'd
for
you
sharing your
say?
story.
Thank you for sharing your story.
Anyone else? Okay.
Hi, my name is Barbara Gilmeister. I won't repeat the conversations that we had 2 or 3 weeks ago, but I'll just add to the amazing presentation that was made tonight. I will say, and kind of go along with what Stephanie talked about, I think that the dimension of what the safety officers spoke about really was kind of more of an emergency. And as anybody knows, that anyone who is suffering from addiction, it's a lifelong journey. So it's called long-term recovery for a reason. So a place like Gilly's house offers long-term recovery for people. None of the men who live at Gilly's house came directly from a police department, or all of the men who come. Now, that doesn't mean that they haven't been involved in the past, but everybody who comes to Gilly's house comes from a treatment center. So maybe that was, you know, someone said that was a step that they should take, but all our men come from a place like Spectrum or NOCAG or McLean Hospital or something along those lines. I just think it's a service that that's necessary. We have men who live at the house anywhere from, I mean, they can stay as long as they want. We have, it's not just, it's a hard way to think of this population if you haven't really like either been to the house or been involved. And I'm just going to say, I mean, right now we have men anywhere from 19 to 68. And it is, the things that we provide for the men there, the structure that we provide is every day. It's 24 hours a day. They all go out to work, but we are there to support them if they need skills, if they need to get insurance, if they need to get a job, if they've never, I mean, we had a gentleman who we realized couldn't read. And we got a tutor to start to help him learn to read. And so those are the things that you might not get in an emergency kind of situation, but those are the roadblocks, and those are the things that set people back into relapse. And so I just wanted to say what I think kind of the different steps that there are to recovery. I also want to say that the Gilly's House provides outreach to siblings who have lost a sibling. We have monthly meetings at the house for anyone to come from anywhere. They can come with somebody, and we provide dinner, and then a facilitator who lost her brother provides an evening meeting for them. We have a mom's luncheon once a year for moms who have lost a child in any way that they've lost a child. And again, this is open to anybody who lives anywhere who wants to come. We have 80 moms who come to this luncheon every year. I also want to say, I realize we're located in Wrentham. I kind of look at it as there are barely any, so we are nonprofit MASH certified sober home. There are barely any in this area. They're certainly not nonprofit, and which has a very different philosophy. But I want to say that I kind of look at it as none of our towns, we're all kind of small towns, none of us have every single service that everybody would need in the town, and we have to rely on other places, just as you have some students who go to Southeastern Vocational High School because there's no vocational high school in Foxborough, that kind of thing. So, or there's no hospital in Foxborough, people go to Sturdy. So I think it's kind of the same thing, the same idea. I'm gonna kind of stop at that, and I just wanted to let you know my feelings on the idea about long-term recovery.
Thank you.
Thank you.
Thank you.
Anybody else? Should we ask if anyone else has
Yeah.
rebuttal or anything? Yeah. I just, in regards to the funding part, we know, I can't, damn nearsightedness, we know the overall total is like $975,000 in that regard. Currently, though, with the funds we already got distributed to us, that's in holding, right? Is it holding somewhere? I assume?
Yeah, it's in a revolving account.
Revolving account.
300 and.
But it's, obviously it's capped, no one else can use it, but for this very thing.
Correct.
So right now, we're looking at through the end of 2024, around 292,000 for the, because we have.
No, we're already over.
We're already over that.
Yeah.
Okay, because it says here on the background that the sum amount averages to 65,000 a year, which would be a single salary, but that's not how it's being distributed.
Correct. So right now, we have the bulk of the funds, and continually, the funds get less and less and less.
Okay.
They go from 60 some odd thousand down to the 50s. But we have the bulk of it already.
Right. Okay.
No?
Sure.
We have one more comment.
Yep.
My name is Lynn Wencus, and I actually live in the town of Wrentham. I'm not from Foxborough, but I did lose my son to an overdose in 2017. And what I would like everybody to keep in mind, regardless, is that people can't recover if they're dead. And that's the bottom line. So whether it's education or harm reduction, and recovery is different for everybody. So I want people to be aware that this may not be a perfect solution and this may not be a perfect solution, but the best thing to do with the money, in my opinion, is to put it, prevention, education. As Chris said, when my son was struggling and alive, the police would come to my house all the time. We had no resources. They had no resources. I have to say, to be honest with you, and not to upset anybody, but I think what the Public Safety Department just presented was amazing. And remember, too, that it's, even though it's overdose money, everybody that they deal with mental health, there's always, if their father's an alcoholic, the kids have, they've experienced post-traumatic stress syndrome, they're more likely to get involved in drugs to numb the pain. So it is a very wide thing, and I understand that you want the best bang for your buck, but if we don't keep these kids alive and educate them, what good is it? Thank you.
Thank you. Thank you.
Do we want to take a vote, or do we want to review? Want to table? Yeah, I'm thinking.
The selectmen are going to be talking about it next week, so we.
Next week, 2 weeks.
In 2 weeks, yeah. No, they meet every week, so.
Can we
Are you guys meeting next week, or Stephanie, are you guys meeting?
No, you know something, I went back and looked, you know something, I think I was thinking of an email that Matt sent, talking about your talk, and I thought it meant he was gonna present, you guys were gonna present tomorrow night at our meeting, so I was incorrect.
Okay.
You guys are doing whatever you're doing in 2 weeks from tonight, as I've been told. 2 weeks from tonight, we'll hear your recommendations.
2 weeks from today, we have another meeting,
I'm
correct?
sorry, 2 weeks from
Tuesday,
tomorrow night.
Tuesday, they meet
So
Tuesday.
2 weeks from tomorrow, you guys will have your meeting, and 2 weeks from today, we will have another meeting.
Correct.
So we could
So we
think about
can
it, you mean?
table our vote until then.
It's up to you.
Yeah.
Is that enough time? I don't know if that's.
I'm not,
And we could have a meeting before that.
yeah.
We just have to post it. I just need,
That's what I'm thinking, because I'm not prepared to make a sound recommendation
You
tonight.
gave us a lot to think about tonight, so you did your job.
Yeah, thank you. That was really thorough. And thank you, everyone's input.
Yeah,
It's
because,
good practice. Gives you time to sink it in, and you might have another question that you could ask somebody
Yeah.
next week. Good practice.
yeah, so are we okay with that?
Yeah,
Yeah.
that's my recommendation.
Yeah, okay.
Table-
Do we
table
need-
To, maybe not to the 2 weeks, not for 2 weeks, I don't think. I mean, that's the public meeting, but if you want to call another one. it's up to you.
If we need to,
That's
we
fine with me.
we can call another meeting before then, just for this, and, because I don't know what else is on the schedule for that week, but.
no,
if
that's
we need-
fine.
Okay.
Yeah, well, I'll reach out to everyone individually and we'll schedule, something and we'll post it in advance
Okay.
in about a week.
Even if it's not in this room, right?
Sure.
You
Yeah.
can get it on.
Yeah.
As long as it's publicly posted, right?
Yep.
It's our
Yeah.
meeting,
Absolutely.
if we don't have the space here. Okay.
Okay.
Does anybody have any other questions for us? We were doing all the questioning.
Thank you for all of your time working on this, please.
It's an
Thank you.
important, we know that it's an important issue.
It's been an interesting ride for us because that's what we want to do. We want to do what's best for the town, best for the health of folks. That's really all we ever care about. And we admit that we don't know everything, and that's why we like data.
She looked at me for that one.
That's why we ask, all of the other stakeholders in town, and for folks with experience and who've had folks in their families impacted by this, because we're also residents, right? So we just want to make sure that we're doing good for our neighbors. So if we can just get a week, we'll post it. If you have anything, and if anyone's watching, if you have anything to let us know, to have us consider before we give our formal recommendation, please send that.
There's no bad decision, by the way.
It's ultimately
You
yours.
guys- Yeah.
I'm
you
sorry,
guys-
not yours, but.
Yeah, you guys will come up with, that's why you're sitting up there. You'll come up with a decision, and there are no bad decisions. They're all good ideas here.
Yeah.
And it's a recommendation, and
Yeah,
you
it's
guys
only
get the
recommendation,
fun.
we don't decide.
Yeah,
We can only
don't
recommend.
have the final
Boy,
say.
I'm helping to decide.
Yeah,
But
so I was like,
This is hard, though. We're gonna listen, this is what you're here for.
Yeah.
This is your expertise, so listen to all the good people here, with good ideas, and, between all of us, we'll make something good work.
Yeah.
Sure.
I mean, all we can do is kind of listen to everyone and make a recommendation. That's what, I was on the board during COVID, that's what we did, and it was very hard to come up with a knee-jerk response, because you just want to make sure that you're thoughtful and thorough. So, all right, so that's the end of that conversation. It was long and
I think fruitful, informative.
informative.
And helpful. So
And
thank you,
helpful,
thank you,
and
thank
give
you.
us a lot to think about. We have some other items on our agenda. You are welcome to stay,
It must exist. There we go.
but it's not required.
As they wrote that through.
I'll always you're welcome to, no?
Thank you
Okay.
very much.
Thank you very much, everybody. Really appreciate it.
Thank you.
Diane, you okay? I feel bad you this whole time. You all right? This is being recorded?
Yes.
Sorry.
That's helpful.
Well, she's coughing. I'm just trying to,
I know.
I'm showing my concern on TV.
All right, so we are okay to proceed.
Yes.
We'll move straight into the underage tobacco compliance updates. We have 3 of them. These are all first accounts, right?
Yes, so,
Can you,
One
Megan,
second.
can you shut the, oh, sorry. Yeah, I was gonna ask Megan. Thank you. Thank you, Diana.
So I just wanted to go over, we were able to do our tobacco compliance. It's been a long time coming. We've been trying to find someone to help us. We found an individual, an underage buyer. So we did go out. So on August 6, 2024, Inspector Megan Mazowski and an underage buyer performed a compliance check at 1:30 p.m. At Express Mini Mart. Located at 126 Main Street. And at that time, the underage individual asked the clerk for a pack of Zyn pouches. The store clerk did not ask her an ID and did not ask the underage individual an age. The underage individual returned to the car with a pack of Zyn Chill 15 nicotine pouches and the change from the purchase. A fine was issued pursuant to 105 CMR 665 in the current Board of Health regulation. After the completion of the compliance checks, I informed the owner of the sale, and the owner stated that they would retrain the employee involved and would not appeal the fine. So I have the product here, a violation notice, Express Mini Mart, and they did pay the fine and said they were going to retrain. So I just wanted to give that to the board and show you that, that was done. And if you've never seen a nicotine pouch,
Matt, I should know because we just did all those regulations, but we don't have it where they have to appear before the Board of Health?
I don't think on the first one.
Not for
I
the
thought it
first
was the
one.
second.
Yeah, it was repeat offenders.
Yeah.
Oh, really? Okay,
I thought it was the second, and I can double check it.
okay.
She was in my
We
office
used
today.
Yeah, we used to say, because we don't ever want to see you again.
Right, exactly.
You just want to say that to someone.
Right. She was in the office today, and she was good about it.
And when she says that she's going
Yikes.
and when she said she's going to retrain, is it just that one employee that made a mistake or
All
everybody?
employees, yeah.
Correct. It was one employee that she had just hired. So, we went over the time, the date that it happened. She knew the employee that was on, stated it was a new employee, and she was sorry, and she would retrain her to make sure it wouldn't happen again.
You can retrain all employees though, right?
Yeah,
That would
I
be a
would
better way
like
to say
her
it.
to retrain everybody.
Yeah,
Yeah.
That's a good.
we can make that recommendation.
Yeah. But so they paid their fines, so they're good.
So then, on August 6, 2024, myself, the underage buyer, performed a compliance check at Foxborough Shell at 10:52 a.m. The underage individual went into the store and asked for a package of Zyn. According to the purchaser, the clerk did not ask for an ID or ask their age. The transaction was completed, and the buyer walked out with a package of Zyn Chill nicotine pouches and change from the transaction. Later that day, the fine was issued pursuant to 105 CMR 665 and the current Board of Health regulation. After the completion of the compliance check, I informed the owner of the non-compliance. They informed me that they would not appeal any fine and they would retrain the individual that sold the nicotine products. So again, we have the nicotine pouches, the violation notice. We have not received the fine for this, and I believe they're no longer the owner.
Oh.
And they,
Since,
yes,
since what, 3 weeks?
yes.
So that guy will not appeal, but we don't know if the new owner will abide by it, probably.
Well, I don't know if the old owner will pay the fine or just go away. You know, and then
Still needs a fine.
he's no longer the owner.
Yeah.
The individual, he sold it, the gas station, to another individual already.
So that new owner doesn't inherit the fines,
I don't believe they would, no.
the establishment?
So that's
They-
one way to
they
get out of
didn't-
fines,
they didn't
everybody.
do it.
Sell your whole business.
They didn't do it.
That's,
It's not the same employees, right? New employees or?
Megan, do you know?
No, I don't believe so. I believe it's all the same employees, same manager.
Then I would
Oh, well, then
think,
it's the same manager, then yeah, they have to be retrained and pay the fine
yeah,
anyways.
I would think if it's the same people, because it's the same thing we would do for food, right? Like, just because you change the owner, if the kitchen staff is the same.
Well, you still need, now we're getting in the weeds.
I think that's
Yeah.
a legal question.
Yeah,
Yeah,
I mean, I
right.
think, yeah, we should check about that, because I
Right, it's a new owner. It was under the other previous owner's authority that this
But same
infraction
establishment.
happened. And the new
Yeah, we
owner
could check into that.
so far is compliant.
yeah.
We could ask the new owner to look at his training schedule.
Correct.
So does I don't have, I should have printed this out. In our reg, does it say that we find the establishment or the owner?
It's the owner of the establishment, yeah.
I would think it's one of the same, but.
Right.
Right.
So even if you changed owners, if the establishment is the
It's
same,
not changing manager. If it was changing manager, it would
Right.
hold, but if the owner's gone, they don't own the store anymore.
yeah, I think we should check on that. I don't, yeah.
Yeah, I
I'm
can
not a
ask
lawyer.
legal for an opinion.
Yeah,
Absolutely.
Okay.
because my concern is when this repeats, or not when, if it repeats. Because is that a first-time fine, or is that a second?
First,
It's first.
it'd be first,
Okay. I just want to confirm.
because it's a new permit, but I can confirm.
Yeah.
It's a new name, it's a new LLC, it's a new everything.
Yeah.
Were any of these done to purchase actual cigarettes or just the pouches?
So we tried, and it's funny, the only ones that he was able to buy were the Zyn pouches. So we tried different things. You know, he asked for a pack of cigarettes, a cigar, different things. But every time he asked for Zyn, for some reason, he got it.
Cigarettes, he was carded.
He was carded.
Okay.
Correct. So we went out to all the tobacco establishments within the town, and these are the 3 that received.
And how many establishments do we have? How many permits do we
I
have?
believe it was 12. Diane, am I correct in that? 12.
25%.
Okay.
So what you find is that if you can do the compliance checks more often, you'll wind up eventually getting like 0 complaints, because they know that you're watching them.
Right.
But since it's been such a long time,
I just wonder if this,
yeah.
like a stakeout.
Yeah.
I wonder if this is just specific to this. I mean, obviously, if they're carding for everything else, and this just looks like, I don't know.
I mean, it says it right on there.
It says, warning, this product contains nicotine. I just feel like it may not be a known entity for the resellers. I know that's what training's about, but I just,
Yeah.
if you ask me, let me,
So it's a nicotine delivery product,
Yeah.
much like a vape, you know.
yeah.
And then
Evidence bag, thank you.
you're welcome. And we had one more. So on August 6, 2024, Megan again with the underage purchaser performed the check at Quickstep Beer and Wine, located at 79 Summer Street at 1:10 p.m. And at that time, the purchaser went into the store, asked for a pack of Zins, and according to the underage purchaser, the clerk did not ask for an ID or ask their age. The transaction was completed and walked out with these pouches. And later that day, the fine was issued. And I reached out to the owner. The establishment was called. He stated they would not appeal the fine and retrain the employee involved. Interestingly enough, on this one, they had not picked up the green card for the certified for the fine or paid the fine. So more follow-up to happen on this one, as well as the Foxborough shell.
So they haven't picked up the green card, or they have refused it?
They haven't picked it up, so I can't say they refused it until I receive it back and,
It sends snail mail.
yeah, oh, okay.
All right, so we'll wait, see what
Yeah,
happens.
so we'll wait on that one. Are you,
Also, they have different dosages.
Oh, yeah?
yeah,
Okay.
I was like, oh, yeah? That was a question, because I have no idea.
It was just
I've never seen one of those before. Okay.
would you like to move on to
Oh, yes.
12 winter?
Yes,
So this, we had talked about this. I had sent an enforcement notice to the owner of 12 Winter Street, as we discussed in the previous meeting. In response, I received a request that they would like to appeal that and have some more time in order to comply with us with those Title V requirements. I believe though that letter has been given to the board, and I just wanted to get your feedback in regards to any sort of, stay or allowance of further time considering the circumstances for that individual.
So I'd first ask about how long do we think this failure has been in place?
So the failure has been in place for a long period of time. We have the file here.
And what does the?
Do you want me to go back to where I started this or before
Previous,
that?
yeah, however.
That's fine. So I think it all began when there was a neighbor complaint, and goes back to, a long time ago, regarding the property. But, what I've gotten from the owner was in '02, he applied to put in a new septic system. Basically, he was selling the house, and I think it was going to fail. So he decided that he was going to, pursuant to Title V, put in a new system in order to make it fix the violation. However, it expired. The system wasn't put in, and they stayed there. They stayed in the home. Basically, I found this, and this is where the paperwork starts, is this expired system. I found out and sent a notice that basically he was in non-compliance. We didn't know about his system and asked him to basically have it inspected. Eventually, it was inspected, and it was inspected in 2022, and it failed. So 2 years later,
But excuse me, Matt, you said that it failed just because it had a cracked tank, right?
so
Did the
let
rest
me-
of the system fail, or was it just the cracked tank? 'Cause that's a little bit different.
so it says, backup of sewage into facility or system component due to overloaded or clogged SAS or cesspool and static liquid level in the distribution box above outlet invert. And the system fails.
Originally, he said it was 2010.
And I believe there was a comment on the tank, but I'm not seeing it at the moment.
So there's no way for sure of knowing, other than the the 2022 failure, that the redoing of the system that they decided not to do 20 years prior didn't know at the time you said it failed, but was it based on the same thing, or did it not fail?
We don't know.
Okay, so it could have been it could have been fine until like 2018 or something like random.
It could have been, or it could have been getting worse.
Could have been
for
getting
the
worse,
last-
yeah.
I mean,
Yeah,
there was
we
a
don't-
complaint we don't know the nature of the complaint 22 years ago,
Right.
but there was a complaint.
So the 2 years was up June 21st, 2024. That was the 2 years from
That
the
was-
date it was inspected and failed.
So the initial 2 years of grace to get the system repaired
Is up.
is up. And the request is for an additional 2 years.
Are there any other complaints from neighbors, or has any environmental tests been done?
No,
Are there any wells in the area,
not that I know of.
wetlands?
Do we have a record of how often he pumps his tank?
I did not look before the meeting. I could come back and let you know.
Is it a small lot?
Yeah, it is is it a 3-bedroom house? There's not even a design flow. The water meter reading was 475 gallons per day. Number of bedrooms, 4. So it's a 4-bedroom home.
Do we know how many people are living there right now?
I don't.
Zillow says it's 1.21 acres.
Okay.
Thank you.
So if it's a single person versus 4 people living there, that eliminates some of the drain. I don't know. We have to take a vote on this now, though, right? Because their request is for.
No, you don't. I mean, you don't have to.
Do we,
Well,
how was it posted?
I think
I
we
can
don't
come
have any
back with the
environmental tests or
pumping.
anything.
I can come back with the pumping records,
I'm,
and if there's any, I don't think
well, he's appealing it, right? So
he is appealing.
we do have to make a decision.
Yeah.
We can take a vote on whether to grant the appeal, the 2-year extension, because that's what he,
Get a shorter extension.
or make it shorter, but right now he's asking for 2 years. We can vote on that and then follow up with any subsequent votes, depending on how that goes.
I just think it's hard to make this without knowing more about the actual, any issues that are being caused. It's hard to vote on something.
We do, there's a couple of things we know, that it is a failed system, because he
Yep.
had an
Yeah.
inspection 2 years ago. So it is failed, but it's not,
3
2
years.
years ago, it was not coming out, puddling on the,
And I can say in the '02 design plan that was never done,
yeah.
that it's within 150 feet of a bordering vegetated wetland.
It is within?
Yes.
Yeah, see, we can take a vote.
Okay.
and see. Can I see, do we know when it was, the property was built?
1956.
Thank you, Zillow. Thank you, Megan.
I love when the paper turns brown.
Yeah, just to show the passage of time.
I know. So this was done 2002. It was approved.
Assuming the wetland's still in place. Or actually, it's been more, they'd be more stringent now, right? 20 years, 24, 2 years
Yeah.
later.
Is there currently a pool, or did he finally put the pool on the property?
I believe so. I would have to check the building department records, but yes, he He pulled the permit to install a pool.
With the failed system?
So I originally denied his request because I didn't know where a septic system was. And I said, I don't know where your septic system is. I don't want you to put your pool right on top of it.
Right.
Because all I have is a failed plan.
I mean, but
So
it, based on this plan, it looks like if it's not right on top, it's what?
So in that
14
discussion.
feet away? Feet away?
I had him do that
That might be an
Title V inspection to find out, and he did, and it
So
failed.
2 years ago, he put in a pool?
Yeah, that's how I found out about it. Because it wouldn't have come to my attention until something like that happens, and you have to look through the file to comment. And that's what I found.
Well,
I don't know. I feel like I still need more info. This is, off the top of my head, I would say no, but there still needs to be some, with grace towards his,
So do you want to,
situation.
do you want to make a motion not to do it, and then we'll make another motion to give a shorter time to?
I think, I still think we're missing information.
I can bring him in, or ask him to come in.
Decision.
Yeah,
That's
I
all
mean,
that's my opinion.
We have this personal letter, which is nice, but that doesn't tell us why, despite having failed inspection, failed systems, a system that has not been fully up to code for over 20 years, we already gave you 2 years of an extension, and you're asking for another 2 years. I mean, unless I'm missing something.
I mean, I sympathize with the appeal request, but I feel like it can't really be on just a basic scientific fact level. I just don't know enough about the failure. That's just me. Like I said, right off the bat, I would probably say no, but I don't know enough about it to really, that's just my opinion. Robin, maybe just have like the year, 1 year.
I have a what?
What do you think, a 1 year extension or a small month?
I wouldn't
Have him come
give
before.
it even a 1 year extension. but-
No? That's what I'm saying, is we can't, I just feel like I don't have the information,
Okay.
but I could be ruled, so you can call it if you want.
Is there any breakout, or we don't know that?
So
2 years ago, there wasn't, but do we know today?
we received, so the town originally received complaints about breakout. According to the owner, that was some pump runoff. It wasn't true breakout. And we haven't had any sort of breakout complaints or anything like that smell since, way back in the files. So
I'm inclined to vote on it as is, and if he wants to appeal that vote, then request with evidence reason to show that there isn't breakout, it's not contaminating.
Pumping it.
I want to see why it's safe to give an extension, because right now I don't.
Well, that's kind of what I was saying. I don't have
Yeah,
enough evidence
right now
either way.
we don't have any information to grant 2 years, because we just have what might have gone wrong, and, and he already put the pool, so I want to err on the side of caution, and if you want, I mean, we can sympathize, but we have to protect
Right.
the public safety and the public's best interest. And right now, we don't have enough to justify an extension.
Okay.
So we can take that vote, and we can make a motion to do whatever. We can make a recommendation after the vote.
Okay. You want to do it? I'd like to make a motion to, should we say deny the 2-year extension of the septic upgrade for 12 Winter Street, pending recommendations? No?
That's it.
Just that's it?
Yeah.
Okay. With that, strike the part about recommendations?
Yep. Okay, that's it.
That's it.
Aye.
Oh, no, you have to second.
Oh, second.
We're all over the place tonight. It was such a long meeting.
I know, this is such a long week. Okay, so now it's seconded. Any comments, concerns, questions, queries? No? Okay.
My only thing is that we recommend to him that if he wants to come and tell us, you
Yeah.
know,
Yeah,
why, he can come back.
yeah, come back for an appeal, right? So we
Yeah.
can offer an appeal with,
Oh.
if he could come with the evidence.
Now I'll
No.
vote aye.
Okay, aye.
Aye.
Yeah,
With the, that's why I said with the recommendation.
No, that's it.
no, the recommendation was in the comments.
It's in the comments.
Yeah, but yeah,
It's not once.
if he wants to appeal that,
Sure.
that extension, I don't know the time frame. I mean, you can, we're trusting you to come up with whatever reasonable time frame to get it fixed. And if he is not okay with that, the burden of proof is on him to come back and get us to figure out why a 2-year extension is safe or not harmful.
Okay.
Not harmful to the environment.
Not harmful, yeah, not harmful, because right now, there's nothing saying that we're protecting the environment.
The neighbors or.
Or the neighbors, or the wetlands,
Everything.
we don't know anything. And we can't, I mean, we have to be objective, and there's no objective measure
Yeah.
to make a decision right now.
Perfect.
Great.
Let it be known that I'm the one who said it in the microphone to deny. That's it. We're all down it.
And then we can move on to the department updates.
Yeah,
So
so,
this is, oh, yeah, sorry.
I mean, I did want to bring something to your attention. Megan and I worked on it for a while. So we had found multiple code violations at the Honeydew Donuts that remained outstanding for quite a long time. And some were real basic food safety and priority foundation sort of code violations, like not having a working hand wash sink. And the owner, because he was selling the property or because he, wasn't going to be in business anymore, just was sort of ignoring that. So we originally sent out a suspension notice because we didn't know the backstory of anything, and just based on non-compliance, fully expecting that there'd be an appeal and maybe swift repairs. And that was sent out on July 29th. However, the owner basically, refused to suspend operations. Therefore, we had to issue a cease and desist order on August 13th. Based on the appeal period had lapsed, he had, because the first suspension, that appeal period has lapsed, so we decided to give that suspension cease and desist order. Again, he refused to cease and desist operations. So I forwarded this information to the Honeydew Donuts corporate office, and the business closed the next day. I guess Honeydew Donuts corporate is going to take over that space, so they wanted to take care of it. But yeah, it was quite the event. It was closed. I'm glad we didn't have to go any further and take further enforcement actions, but you hate for that to happen in your community, so I wanted to bring it to the board's attention and sort of let you know about it.
Okay. Thank you. Any questions on that? I have
There's
one.
do the corporate offices, do they have a plan on when they plan on opening back up, making the repairs and opening back up?
So I think it's the whole facility is now under new ownership, so I think that's a little bit up in the air. So
Okay.
the gas station sold, and now, the Honeydew is gonna do some repairs and get back in there. I don't have a time frame.
Okay.
I know that is the plan, but yeah, I don't have any specific dates.
And can we get some inspections in before they open up under the new ownership? Kind of, are we treating this like a new business?
So Honeydew, yeah, we would
Okay.
treat them like, because it's going to be a new owner.
Yep.
So it would be a total
Okay.
new permit. And we've already done an inspection of the gas station or the retail portion
Okay.
when the new owner took over.
Okay.
Did you have a question?
I had another follow-up question for department update that's not listed.
Okay.
Once everything was
No,
done.
that's fine, I'm good.
Everyone's done? Okay. Just in regards to, I got personally contacted again about 7 Revere Drive. I know the pool was drained. We talked about that last time. Permits were being, building permits were submitted. I just don't know if the building department has gone back and checked on everything permit-wise.
So I did reach out to the building department. He did file for a permit. I believe the permit was accepted by the building department, and now he is free to make the repairs. It will have to be approved by the building department. It's going to have to be inspected. But I feel he has an approved plan submitted into the building department.
Okay, because the complaint was that they were already doing construction and also doing it on Sundays. So that's why I was reached out to, because of the noise ordinances and stuff. And I said, I recommended they reach out to the police department, because my understanding was the civil code was to make noise and do construction on weekends or Sundays, you need a permit from the chief of police. Is that not, or is it just from the building department? Maybe I was mistaken.
I believe it's a chief of police the way it's written, but I can double check that.
And this person was told that the police said it's not a criminal offense, so they have nothing. I was like, but it's in the, I don't know what to say to that. So I don't think we can do much, unless it's outside of, I just don't know if it's just in the case of the building right now, or if it's
So-
a noise ordinance type thing. I'm just not sure.
We
So I don't-
approved after hours for Gillette Stadium when they did the work there, so I don't know what the difference is, but I can look into it and.
Yeah, that's what I was wondering, if it just the chief has to issue it
Yeah.
for Sunday repairs or construction, or if it's a noise thing. That's kind of a clarification on our regs that I don't remember. And I should have checked it before I put this on TV and make myself. But I just wanted to double check on that. Thank you.
Yeah. And that's it.
Okay. Great. Any other comments, questions before we get to the minutes? No? Okay. I like the minutes. How do we vote?
Yes, they go on for a bit. I didn't get to look at them really much detail, but that's fine.
I have a question on page 4.
1, 2, 3, 4.
In the middle, when it says, also the board stated that this would help decriminalize the stereotype around addiction. Did we just want to say destigmatize?
Yeah.
Instead of decriminalize?
Where are we looking?
In the middle of the, it's 1, 2, 3, 4, 5, the 6th paragraph.
1, 2, 3, 4, 5. No. Oh, okay. Decriminalize.
Oh, yeah,
I think
it was
we-
destigmatized, is what we said.
It was destigmatized.
Yeah.
That's right. If we said decriminalize, it was a. I think we probably, if anything, we used it wrong, because everywhere else we use destigmatized.
Yeah.
Yeah. That was another long meeting.
Well, it's all for important stuff, so. It's all
All right,
for,
I'd like to make a,
all for
oh, are
important
you going
stuff.
to make the motion?
I was just saying, it was long, but it's all for important things, so.
Yeah.
That's good.
Yeah.
I'd like to make a motion to accept the minutes, except to change the word on page 4 from decriminalize to destigmatize, the minutes of August 5th, 2024.
Second.
Comments, concerns, queries? No? Okay, how do we vote?
Aye.
Great. All right, it's 9:30. Oof.
We did it.
Oh, all right.
It's a late
Are
night.
we adjourning?
I'd like to make, oh,
Go ahead.
I'd like to make a motion to adjourn.
Second, vote aye. Great.
Thank y'all.